So I'm going to talk to you about something different, a different approach in healthcare for Ontario. And it's really about rural health hubs for rural and northern communities. So for many years, obviously, people within the system have recognized that there's problems with this whole siloed approach to healthcare with hospitals and long-term care and home care and passing people back and forth in between these things, and you send them from the hospital into home care, and then they ask all the questions again about who are you, what's your problems, what happened in the hospital, and this is mainly because we have funding that's in separate and distinct envelopes, and we don't have a way really of. Okay, is that better? Okay, thank you. And we don't have a way of really sharing or pooling those financial resources and sort of improving that coordination of care. So again, this is nothing new, and it's really that desire to have much more of an integrated system, however you do it, but trying to either traverse or connect those silos better. We certainly have one solution that's been emerging, and that's bundled payments. Very much that's much more of an urban setting type of thing where hips and knees, instead of having somebody, an organization such as a hospital, do the acute replacement of the hip or knee, and then they get passed off to home care, and then if there's a readmission or revisit or visit, a revisit to the emergency department, nobody really knows who's responsible. And so in the case of bundled care, what they're doing for more integrated care is the approach is to give one set of dollars to, in this case, for hips and knees, it would be the hospital, who's then also responsible for that care in the community. But then they're also responsible for the outcomes. So responsible for if there is a revisit to the emergency room or a readmission, it's kind of, who to blame. And it's really working out well for patients. So this is really an emergent solution in much more of the urban setting. But what we did do at the OHA was create a health hub paper, and it was really at the request of then Minister of Health Deb Matthews, and she made that back in 2012, saying that local health hubs or rural health hubs was an idea whose time has come, and was really interested in advice. So we created a paper. And sort of the definition of a rural health hub is a local integrated health service delivery model where most, if not all, the sectors of the health system are formally linked in order to improve patient access, and a single funding envelope is provided to a fund holder or a single organization to manage the health of the local population. So what's included in that? Certainly the core components of it would be the normal thing you would expect from a hospital of the emergency and inpatient care. It would be comprehensive primary care, home and community, or home care and community, long-term care, mental health and addictions. And that doesn't mean that there's not other partnerships that have to happen. Certainly you bring together all those services within one area. But we still have other parts of the health system, whether it's public health or ambulance services, and getting into much more of the social side of things with recreation and even education. So even though it's one entity from a health care standpoint, it still really needs those other partnerships if we're going to really improve health outcomes locally. And of course, we don't, in small communities in Northern Ontario, it's not like every service is provided in that community. You still need to travel. You still need to, for some things, have to go elsewhere or have another service delivered into that community. And so you still need also some sort of regional referral center. All services can't be provided within that small community. And for example, if anybody needs a double lung transplant, University Health Network's the only place that does it in all of the province, so that's where you go for your double lung transplant. So it's not comprehensive, but it's pretty close. And here's where it starts to enable that integrated approach is by addressing things such as the funding, which is part of the reason we have silos now is we fund different silos, and therefore people have to be passed back and forth. But if you actually created a single funding envelope and made one lead organization responsible for that, then you have a lot of benefits that start to fall from that. And certainly it starts to break down those silos. You can start to reduce administrative costs. Right now, all the different health service providers enter into what's called accountability agreements with their local health integration network, the Lynn's. And in some cases, we've got organizations who are may be involved in various services, and they're doing, say, 3 different accountability agreements, even though they're one organization, 3 different accountability agreements with their local health integration network. And it's certainly consistent with the system trend to population-type based funding. So trying to allocate the funds in a way that locally can address the needs differently, or do it based on the local pressures, the local availability of services, and really focus much more on those health outcomes, as opposed to within that silo, that particular sliver, hey, I did my job, now I don't have to worry about really the outcome, I just did my job. And this starts to take a more holistic approach to what that outcome is. How big should local health hubs or rural health hubs be? Certainly what we've found is the application of these things really is in the north, and in those very isolated communities. There are possibilities of doing it in the south, but usually many of the southern areas are pretty close to an urban area, and it's not quite the same lack of services or lack of home care, or there's a better ability for home care to, say, in a London area, stretch a little further and reach into some of those smaller towns. But it's really hard when you're up in Thunder Bay to reach into Manitowage, which is, hours and hours away from Thunder Bay. And so, certainly for those more remote communities, it really allows them to have a more flexible approach with the funding and how to use it. So, and right now, all these organizations, I said, enter into accountability agreements with the Lynn's. They also have to provide, by legislation, quality improvement plans. And again, it's done on a very siloed basis. So right now in a very small town, you'll have the hospital who has to do a quality improvement plan, and potentially the home care providers do a quality improvement plan, but it's not taking a look at the person as a whole and trying to get to those outcomes. So this really allows for the idea of trying to create a better approach to quality improvement within your local area, to say, okay, how can I improve this care of this person or persons like this, and make the changes that I need to get that best outcome. When it's all chunked up into different quality improvement plans with different goals, it just really doesn't serve the person well. So from our standpoint, certainly the prerequisites for a rural health hub is certainly that single funding envelope. It's really, really important to have that because that's where you start to allow for that flexibility in how you spend the monies to address the local needs. And the core health services can be formally linked in 2 ways. One, clinical integration through clinical pathways and quality improvement processes, but also through an integrated governance and management process and structures. So again, when you've got one administrative group responsible for trying to create those better pathways and so on, it just works out so much easier, and there's so much more of a focus on that end outcome. So IT is another piece. So it's really tough. Again, I spoke earlier about the idea of when you come out of a hospital, you go into home care, and they start that whole list of questions again that you were asked when you went into the hospital, and it's all the same questions, and you're starting to wonder why why didn't they have this information? Like, I'm already in the system, I've had my problem, and why do I have to answer this 2, 3, or 4 times? You know, with IT, again, you can have that whole journey of the person, everything at your fingertips as, you know, as the healthcare provider as you move from hospital to home to primary care. And certainly you still need sufficient critical mass in terms of size of a catchment population. That's why most of the things most of the communities, when we've been talking about rural health hubs, has been in those areas where there already is a small hospital, because generally that's why the small hospital is there, because of that critical mass. I know up in the north it changes at times as mines close and paper mills close. You know, the critical mass that was once there isn't quite the critical mass that is there now. But quite often people try and substitute that with trying to do tourism or retirement homes or retirement villages and those sorts of things. So there's a way of trying to keep that critical mass still the same to support that community. So the benefits. So it's not just about, you know, trying to create a funding envelope or a single governance and having less administrative costs. It's really about improving client access and supporting a patient-centered approach to coordinated local health services. And just to give you some examples, that if our friend from Manitowoc, Jocelyn, was here, he would talk to you about, you know, we're probably saying that that's the most advanced health hub that we've seen, how things are different, you know, in a health hub environment. They had a patient or a person in the community where home care would come in and change the dressings on their wound. And they'd come in from 2 hours away, the home care nurse would come and dutifully change the dressing on the wound and, you know, keep coming back and doing it over and over and over, and 2 years later. But because they had then created this health hub environment, you know, a nurse in the hospital and you know, others in the health hub started saying, hey, instead of changing the dressings on the wound, why don't we actually try and fix the wound? And they started educating themselves on the wound care, you know, and I can't remember what hospital they did it through, but, you know, they started using telehealth and that sort of thing, educating themselves, and they worked really hard and they actually addressed the wound and it was gone. Like, that's the benefits of having everybody around that person in the community and focusing on what's the right outcome, not just what's my job to do and changing the dressings, but actually what's the right outcome for this person that we want to achieve, how do we use all our resources to do that and make it happen. And so that's just the flexibility that happens. Or somebody showing up in emergency room and knowing that they're actually part of the, they're on the roster of the community diabetes nurse who goes out into the community and saying, hey, let's get her from down the hallway because she's co-located with us, and bring her in, and she can tell us exactly what really needs to be done, and we can get this person, you know, back out in the community right away, as opposed to struggling with a new person or nurses who see this person as a new person. Let's get somebody in here who knows them and treat this person, you know, as a joint effort. Strong links to community options for hub clients. So again, knowing what are all the possibilities when you're one organization as opposed to a hospital sort of just discharging somebody, knowing what are all the possibilities to not just finish the acute care stay, but how to keep them healthy and whole in the community and not have to, you know, deal with them when they come back again. The idea is not for them to come back again. And again, as I said, supporting a population health mandate. When we're all together on this, we can take a look at those bigger outcomes and not just our own outcomes. You know, the administrative synergies, that's important in these times too. Like, dollars are tight. And so, you know, despite it not being the main goal of it, it helps by creating some of those administrative savings and so on. It just makes it a little more viable in those communities for the healthcare dollars that are going in there. So, and there's been lots of previous work done that has led up to this, whether it was a rural and northern healthcare panel, some work by what was then called the Joint Policy and Planning Committee on a multi-year review of core services and what should be produced in hospitals. You know, and so there's been a lot of different approaches to it. And although we've got on here other models of decentralization in other jurisdictions, whether it's Australia or the US, it's really quite interesting because we actually started to phone around to other countries as we've been working on funding models for small hospitals. And we'd phone Australia, and you know, we'd phone the US. We actually had Pennsylvania come up and speak because they were trying to change their small hospitals who were financially going under and trying to come up with different funding models and focus more on population outcomes. But they're actually really interested in what we're doing in rural health hubs. All those people that we phoned around to talk about funding, when they heard about what we're trying to do with rural health hubs and create that one, you know, single governance, single funding envelope, focus on health outcomes, they were actually really interested in what we're doing. So we are in some ways leaders this way. And even the Northwest Lynn, they created a blueprint in 2012, and very much the idea of these rural health hubs or local health hubs are part of what they're trying to do. So they've got a multi-year plan to, you know, put this blueprint for healthcare services throughout the Northwest Lynn, and this is at the center of what they're trying to do. Now, it's not like right now we just have hospitals who are just doing hospital things and trying to move into this hub environment. There's lots of hospitals already who are doing multiple things out there, and they're managing whether it's hospital services or long-term care or community services. We have some hospitals who are actually managing family health teams and community health centers, and in some cases even for home care. You know, even though it's legislatively all very restrictive as to who can do this. In some cases, we've got some of our small rural northern hospitals registered as the preferred providers for the contracted services for what was then CCACs and are now LHINs. And I know, and so here's one that I put on here for Ray Hunt from NOSM, who's here, Espanola Healthcare Campus, as an example. You know, these aren't things that OHA sits in their offices in Toronto and says, gee, I wonder what innovative thing we can think of. No, we're smart enough to know that it's our members who are the smart ones, and we have to go and find out what they're doing that's innovative and exciting, and how do we then take that and spread it. And so, for example, the Espanola Healthcare Campus, you know, it's a 79-bed campus, but it's 15 acute care beds, it's got a couple of chronic care beds, it's got something called LCAP, which is very much nursing home beds, it's got long-term care beds, it's got a assisted living complex, seniors non-profit housing complex, you know, plus the family health team on site, CCAC offices, sleep lab, private physio, all co-located in one area. And that's really what we're after when we're talking about a health hub. Knowing that you can go to sort of one place and they'll be able to treat you with the right services. Not that you go to a place and they give you the services that they have, but by going to a place like this, they can actually sort of plan what are the services you really need, we've got everything here, and do the right thing. I know this is hard to read, as a couple of these others will be, but I just wanted you to have these for the future. And again, this was done a number of years ago, but it's just to show that it's not just Espanola, but we have a number of other organizations out there that do not just acute, but a lot of other things when it comes to long-term care and so on. So I think we've got about, in the province, like 34 hospitals that also own long-term care beds. And this again is just to say, hey, you know, some of these dollars are significant in these other things that they also manage, whether it's family health teams or mental health and addiction services or housing or long-term care. But there's lots of different things that these emerging organizations are doing. So in fact, as we went over time, we also even have created a rural health hub implementation guide from the OHA, and it follows through on a number of our other reports. But the implementation guide was really meant to try and help organizations or communities actually move down the path of creating these rural health hubs. And in fact, if you go on our website, there's also a video that we've done earlier this year to showcase one of our health hubs and how it's different for the patient. Like, what makes it different? Why is their journey, their experience, their encounter different? So with the guide, again, just trying to help communities move down this path, trying to make sure that people understand that there's benefits when it comes to better coordinated care and patient navigation, and that the model has to be flexible. Because although we have places like Manitouwadge and Espanola who are well down this path, we have others who are a little bit down it or haven't even started. And there's not even a right way, like, you know, there's not a perfect cookie cutter